pathologist this morning. They had sent your lymph node off to somewhere else. And what she tells me is that this is a type of lymphoma called a diffuse large B-cell lymphoma, okay? And I know Dee's talked to you a little bit about the chemotherapy, kind of what we would plan. She had mentioned to me, you kind of asked what your cure rate would be. There's one test that I'm waiting on that will give me the answer to that question. If this is a standard diffuse large B-cell lymphoma, meaning that it doesn't have a couple of mutations that we're testing for, the cure rate's about 75% with chemotherapy, okay? It's something that we watch afterwards because there is that risk for it to come back, but still the cure rate's pretty good, okay? If you have one of those extra well, you actually have to have 2 or 3 mutations, the chance of cure is a little bit lower with chemotherapy, okay? So a little bit more high-risk disease. I should have that by early next week. That was why I called them this morning. I think it is not going to change anything about what I would want to do for you treatment-wise. Primarily because some of the other regimens that we would use are more aggressive and a lot more toxic. And I think that what Dee has talked to you about will do the best job of controlling your disease, hopefully curing your disease, with the least amount of toxicity that we can manage, okay? So, always we kind of have to think about all those things when we're talking about treatment. Because you have so much lymphoma on your scan, I think I would feel better doing your first treatment in the hospital. This particular treatment is one we do as an outpatient, kind of as a general rule. But, it is one where there's the risk for something called tumor lysis, which lymphomas respond rapidly to chemotherapy, and if it breaks down really rapidly, sometimes there can be kidney injury, there can be electrolyte abnormalities, and those are all things that we can monitor real closely in the hospital. They're things that we can replace pretty quickly, and I think for the first one, I'd like to do it in the hospital. After that, as long as you've done well with it, then I plan to do the remainder of the treatments in the clinic, because it's a one-day treatment every 21 days, okay? Now you guys live at Fayette. We give chemotherapy at our outpatient clinic at Fayette. So if you want to follow with us there after the first treatment is done, then I'm happy to have you follow up there. If you'd rather make the trip down here, that's fine too. I do both, so you can think about it and let me know.
The chemo goes in, and it don't just kill cancer cells, right?
Right.
It
and
kills everything where it goes.
Right. So what chemotherapy does is kill fast-growing cells. So the ones that we worry most about are blood counts. So her blood counts will get lower, maybe low enough that you need a blood transfusion, maybe not. The white blood cells get lower, so she's more at risk for infection. We actually give you a shot to boost those so that the risk is lower. So we do something for that. And it can decrease the platelets, which increases our risk of bleeding a little bit. And it is certainly something where we may have all of those problems, we may have none of those problems, but it's something that we monitor pretty close, and if you need blood transfusions, we do, okay? It works on fast-growing cells like hair, so your hair will fall out with this treatment, okay? It will grow back when we're done, but it's something where after the first treatment, right before you come back to see me, it will start to fall out, and after the second treatment, usually the rest will fall out. Okay. It can work on mucous membranes, so sometimes you can get mouth sores, that kind of thing. In general, people do pretty well with this though. The biggest complaint is fatigue, and that's something where kind of the way things work is as we give you chemotherapy, if you're going to have nausea and vomiting, usually it's within the first couple of days, first 2 or 3 days, that usually gets better, and then the blood counts go down over the first 7 to 14 days. That's when you feel you're most tired and where the blood transfusion needs happen sometimes. Then everything gets better. Appetite gets better, nausea gets better, blood counts get better, and they come back up that last week. And then you come back to see me and we kind of do it all over again. So each period, that time where you feel tired may be a little bit more, okay? But typically we would do 6 treatments total. I usually do 3 and then do scans to make sure everything looks good. But honestly, by that point, really a lot of the symptoms you're having from the cancer itself should already be getting better, so we know that the scans are gonna look better at that point.
But in the meantime, she eats nothing.
No, she can eat if she wants to.
You
And
know,
she should, as we shrink all these lymph nodes that are in here, she should be able to swallow things
oh,
better.
she's swallowing good now.
Okay, so, are we still doing the TNA
No
then?
appetite.
Yeah, I think as we treat the cancer, that's gonna help. You have to help us though, you know, part of your job is to eat and drink and be active. The people who do those things, who eat good, who drink good, who get up and they do better with chemotherapy. So some of it falls to you. Even the days you don't have a great appetite, you need to work on eating something. You know, the TNA, we can give you nutrition that way, it's just not as good as eating by mouth, and honestly, it puts you more at risk for infection. So long term, I don't want you on that,
You know,
okay? How much are you eating in a day now?
How do you explain
she's eating about a half a spoonful a day.
it? No. He bought me one of those smoothies, banana strawberry, and they had 160 calories,
Okay.
and I got that down.
Okay,
And I had 1 or 2 pieces of bacon,
okay,
and that's about it. My drinking is my worst part.
so that's something that you gotta work on for me, okay? It's important. And like I said, we can do this the TNA, but it's something where long term, it's better to get your calories in the other way, okay? And I think as we treat your lymphoma, I think that you're gonna feel better and eat better. I think her appetite will be better. You know, I think a lot of the symptoms that she's having are from her tumor. And I think as we treat that, she's gonna feel better, okay? You know, the biggest thing is just working on getting that started. Now, Dee mentioned that y'all had asked about a second opinion. Certainly, if you would like to go and see another oncologist, whether it's at UAB or MD Anderson, we could get that set up. But it takes time,
That's right.
you know, so,
Yeah, that's what she worried about the time.
yeah. You know, so it's up to you. I'm always happy to have you have another opinion if you want. Because again, this is you and us taking care of your cancer. I want you to be happy with your care, okay?
Somewhere along the line, it was mentioned bone marrow.
So we can do a bone marrow biopsy. I think that it changes very little about what I do treatment wise. You know, looking at your PET scan, there is some comment that your bones are active, suggesting you may have a little lymphoma in your bone marrow as well. The way to know for sure would be to put a needle in your bone marrow and biopsy it. But it's not going to change what I do for you treatment wise, and it doesn't change your staging. So, you know, I think that it's really not a necessary component of the workup. You've had plenty of biopsies, and I think I'd rather just avoid doing any more if we can.
Until we get to the end to see if that's going.
Yep, and we'll do all that by scan, okay?
Good.
So I think, you know, overall, I think treating your cancer is gonna make you feel better. You know, it's just getting started and getting things done. I know it's always anxiety provoking to hear all of these things, and it's a lot to think about. But ultimately, we tell you these things because we wanna take good care of you, okay? You know, we give you all these side effects of the medicines knowing that probably you're gonna do just fine. But you need to know that those are all things that are possible. That way, you know, if you have a little nausea, you know, that's normal, it's okay. There are medicines we can give you for that if we need to. You know, just a lot of things that we tell you about that you may not have any problems with at all. So.
You see, at daytime, she's usually pretty good, but at night, she's got a lot of anxiety, she's scared,
Sure.
she falls asleep and jumps, you know.
Sleeps
Get
with
the
the-
ice cream off of
with
me,
the lights
I want
on.
ice cream on me.
Yeah.
And she's peeling potatoes and just all kind of stuff. And we got thinking it must be something in that
TPN.
bag
Yeah.
that was doing it. But then we read online that it says, by you not eating can also cause that.
certainly, you know, I don't know that there's much in the TNA that would cause that. You know, certainly the steroids that they have on can mess with your thinking. You know, certainly not eating can do it. Sometimes it's just nighttime is where we have the most time to kind of think about things, because it's quiet, calm, and dark, and that makes anxiety worse too, which also can affect the thinking. You know.
She wants me to stay up all night with her.
Yeah. Do you take anything to help you sleep?
I've tried, what's the name of it?
Ramron.
Remeron. Didn't like it too much, huh?
No, it don't really work.
It didn't
It don't
Didn't
work.
Okay. Have you tried anything else?
She wants something that's gonna knock her out until the next day.
The Amazon or anything.
The Ambien?
Yeah,
What'd that do for you?
about the same as Ramrod.
Okay.
And there was one more, what was it?
Xanax?
Yeah.
Carolyn and Michelle and me, we probably get an hour and a half all put together in a night.
Okay. Have you ever tried just melatonin over the counter?
No, ma'am, I've got some, but I haven't tried it.
We all worried about her, and she worried about herself.
Sure. Try the melatonin. The reason I suggest that is that's something that we all produce naturally. So when it's time for us to go to bed, our body knows that, and we get a nice spike of melatonin. And then, you know, as we sleep, that wears off and we get up. You know, sometimes with the blindness, our circadian rhythm is off. So we don't produce the melatonin like we're supposed to because we can't see light and dark. And it may be that will help you more than anything. Try it and see.
How many milligrams?
So usually the starting dose is somewhere between 5 and 10 milligrams.
Yeah, I did my kids on 5.
Yeah, I'd probably start with 5, and then if that's not enough, kind of bump it up a little bit. Okay. But try that for a couple of nights and see how that does for you.
But we're reading that if you have a red light in the room, and then a fan running, and they call that pink noise, but see, she wants the lights on in the room all night, and that simulates the sun.
Yeah.
Time to get up.
I wonder how you do with the red light, because it would be sunlight, it just wouldn't be bright.
Color, I wouldn't know it was on.
Right, but you would know there was some light there, it just would be less of it.
Yeah.
You know, more like a dusk as opposed to sunlight.
Don't you have it on the shelf?
And we had it off.
Turn it off.
Yes, ma'am, we did.
We'll try the melatonin and see how it does for you.
Okay.
So, what do you think about everything so far?
I think I will.
That's okay. It's perfectly okay to not know. Okay. The
I wasn't
ultimate,
expecting this,
what were you expecting?
that everything was gonna be okay.
Well, everything I hope will be okay. It's just you have a process that we need to treat to try to get you better. Okay?
I'll tell you right now, I'm a chicken.
That's okay. We see all manners of people here that we take up care of for their cancers. Okay? Now some people are so stoic they won't tell you they're having any problems, and other people who call with every problem.
Yeah.
Wherever you fall on that is gonna be fine. Okay? We're here to help take care of you. So if you need us, that's why we're here. Okay? And ultimately, we want to do what's best for you. Try to get this taken care of so that you feel better. Because I really, truly think a lot of what's been going on with you these last few months is the lymphoma itself. It's something that we can treat and make better and should make you better.
What causes lymphoma? What causes that?
It depends. Most of them are not genetic.
It's not genetic?
Yeah, most of the time they're not. This is something that typically is.
Is it from smoking?
Not typically from smoking.
No?
Either. But, you know, we don't have a really good reason for why we develop some of these lymphomas. I suspect it's some of the exposures that we get to things. You know, there's no definite, you know, smoking to lymphoma risk as far as that goes, but that may be part of it.
Didn't
Yeah,
you say
now
you
they-
used to wash daddy's clothes, mama, would have some kind of something on them?
Is this an aggressive one or just?
It's one of the more aggressive ones, so what's popped up has come up pretty rapidly, but it's the reason that treatment will make it better pretty rapidly.
But you call this the stage 4?
Yes, based on what it looks like.
Is that the numbers furthest it goes?
Yes. But for lymphoma, staging doesn't mean quite the same thing that it does for other tumor types. So a stage 4 colon cancer would typically not be a curable process. It's treatable, but not curable. A stage 4 lymphoma is curable, oftentimes.
And treatable.
Yes.
So you got two of them.
Yes. So it's something where, still there will be a risk for it to come back. It'll be something she's got to follow with us for. But,
Every 6 months.
Well, we do every 3 months
Oh.
for probably a year to 2 years, and then every 6 months after that. But, that cure rate is 65 to 75% if she does not have those mutations that I'm waiting on. So that's pretty good.
So what are you thinking about the results? What are you thinking about the results?
Oh, I can't guess at that.
Yeah,
Those should come early next week. I talked to the pathologist this morning. She hopes to have them Monday afternoon. So kind of my thoughts were maybe we could admit you early next week, Tuesday or Wednesday, to do your treatment. That way I'd have them, it's something where if you wanted to come see us in the clinic at Fayette on Tuesday, we could admit
we'll
you.
probably
for
just
now.
come here. Won't we, y'all, Mom and Dad? Yeah, we'll just come here.
Okay. Then I'll plan to do that on Wednesday. Okay. I won't have everything Monday. I don't think, so why don't we plan on Wednesday then?
Okay.
So we'll be on the second floor?
Yes, be on the second floor. Okay. Now, the one thing that we're gonna need to do is change out this thing that's in your chest. Okay. That,
Put it in at the hospital.
yes, but it's one that probably should have come out before she left the hospital or changed to something more long-term, because from what I understand, that's still a central line. Yeah. Okay. Yeah. So,
Can we wait till we come to the hospital to do
if you are using it, then yes.
it? No, I guess we are.
Yep. Hey, it's all up to you if you want to get back on that TPN. It's all up to you. You're the boss.
Those are designed not to be in that long, so there's a little risk of infection with it staying. It looks good and clean, so just make sure you continue to take good care of it.
The nurse
like
does
you
it
do.
every Monday.
Yeah, but, we'll need to change that out when you get admitted, okay? Put in something that can stay in a little bit longer. It'll be similar, just we'll have 1 port instead of 3.
It'll be like like a port in the chest, right?
Well, probably I'd just put in a Groshon, which is very similar to that. It sticks out, but it's just 1 port, and it's designed to be in for months. Where so that's really short. Like when you pull it out,
Yeah.
the length of it total is about this.
Wow.
The thing that we will put in, the Groshon, tunnels up into her neck and down, so it's probably about this
So
length.
that means she goes to surgery for that.
No, it's similar to having this put in. I mean, it requires a little bit more kind of tugging, but there's no stitching or anything that happens. It's just harder to pull out, because it's,
Bigger.
they're pretty good, okay? But it's easy to remove when we're done with it, and I think that'll be okay. So I'll plan on bringing you back on Wednesday. Okay, I should have those mutation studies by then, and we'll plan to admit you that day, okay? This first treatment, typically I would run over the course of a day. I think for you, what we will need to do is run one of the medicines over 24 hours, and then give you the rest of the medicines the next day. Primarily because the rituximab, I'm sure she talked to you about this a little bit, the rituximab is an antibody to one of the things that lymphoma cells have.
Yeah.
People who have kind of big bulky disease like you have, sometimes will react to the medicines, kind of flu-like symptoms, little fever, little chills, and it's something where if we run it really slow, we have less risk of that. And so I think what I'd like to do is run it really slow.
That's right.
Yeah.
Let's run it
And
really
it's
slow.
not something that, is dangerous, but it's not comfortable, so we just wanna run it slow. If you don't react at all to it this first time, you shouldn't react to it any of the other times. But I expect there to be a little reaction at least, because we've got pretty big bulky lymphoma. And that's just one of those things. It should die off rapidly, and so you get those reaction symptoms. But if you don't react at all the first time, you should not the second or third time. If you react a little, that should go away with the next couple treatments. Okay.
I think we just wanna know that we, and Carolyn is doing the best thing for her problem.
Yeah, I understand that.
That's-
You know, and like I said, it is one of those things where if you wanted a second opinion, I'd be happy to send you. You know, it just takes a little longer to do it, you know? So you certainly can think about it this weekend, talk it over. If you'd like for us to do that, let me know, be happy to. Cause again, I want you to be happy with your care. I want you to feel confident that we're doing the right thing for you, okay? But two, there's a balance. There are a couple more aggressive chemotherapy regimens that I would typically use if she were to have those mutations. But I think physically she would not be strong enough for those, not right now. You know, she's not eating and drinking good, you know.
Right.
So I think regardless of what those mutations show, I probably would go ahead and start with what we've talked about today. And then if she does well with it, we can always adjust with the second treatment if we need to.
You said that she should begin to feel better.
With treatment, yes. She
How
should.
long?
Yeah, usually within a few weeks, people start to feel better. But you've gotta help us, okay? You know, your job is to try to eat and drink a little for me.
Yeah.
Okay?
How much should I eat a day?
So a normal person needs 1,500 to 2,000 calories a day. I don't expect you to go from no calories to 2,000 calories, but I want you to start working on it, okay? If you can get 500 in a day, you know, that's 2 boosts, basically, you know?
Well, you know, like I got her a smoothie and it was 160 calories, no sugar.
Yeah.
But that's not solid, it's liquid. Does it matter?
Well, solid is better than liquid, but if all we can get in is liquid, that's better than nothing. You know, so if I have to pick, you know, liquid over the TNA, yes. Solid and liquid would be better. You know, but still, if we're not able to get in some solid things, start with the liquids. You know, you
If she
can.
could, if, we haven't tried it, but if she could eat baby food.
That's fine. I mean, baby food doesn't taste real good.
Oh, yes, it does. I love baby food.
But Sharon, she loves it.
The fruits are probably okay, but like
Any of
mashed up like peas and turkey.
I like it. I eat it. I would eat it.
That stuff, oh gosh, the smell of it will
I
knock
would
you
eat it.
over.
I like it.
But I don't care how you get it in, okay? I just need you to work on getting some things in, okay? Because the TNA long term is not what we need, okay?
So would we-
temporarily it's fine.
So, are we still gonna do the TNA bag of fluids on her, or what?
For now, until she's eating more. We gotta
Okay.
do, you know, you gotta get something.
Because we just got a new shipment in yesterday.
Yeah.
That's why I was asking that
So,
question.
but long term, my hope is that as we treat the lymphoma, that really the eating's gonna be better. I think, you know, it's something where I think her appetite will be better. I think you'll feel stronger. I think overall, she's just gonna feel better once we treat this. I think the reason that she feels bad is because she has a pretty active lymphoma in there. Okay. Okay.
So we don't go for Wednesday.
So I will plan on Wednesday. Okay.
Do we have to be here at a certain time at the hospital?
Well, you'll come here first. I will
Oh.
get you from the clinic.
Oh,
So-
okay.
They're gonna give us a time and.
So when you leave here, they're gonna give you a time. It'll be sometime Wednesday morning.
Okay.
And then we'll get you admitted. And it may be that it takes me the rest of the day on Wednesday to get the, well, she'll have that. We can use that till I get her catheter changed out. She'll probably get things started on Wednesday afternoon. Okay. And we'll just go slow. Okay. Does she take anything for anxiety or depression?
No.
Do you feel like you need something?
I kind of say yes.
She
I'm
has-
sorry to say it, Mama, but yes. I'm not the kind of person that likes to take pills.
She had so many medicines on the counter.
Yep.
It looked like enough for an elephant.
Yeah.
But before this, I didn't have one while I did have an aspirin there.
Yeah. Well, I know you told me in the hospital you just hadn't been sick.
Oh,
So, and, you know, my hope is to get you to where after all this, you're not sick.
I hope you're right.
So what she's probably asking, do you want any kind of medicine to help you calm your nerves down? so she can prescribe it.
What's a good one, then?
You have to ask her about that one. I don't know.
You said you didn't like the Xanax, right?
Yeah, it's not that I didn't like it, it didn't do anything. When I
Those
did
were
it,
It was only 5.
It was a 0.5.
Mm-hmm.
It's pretty decent little dose.
I think that's what it was. I think. That's when they ordered it for her for the PET scan. With Dr. Zone. Yeah.
So you only took it for
Just for the PET scan.
just for the PET scan, so you hadn't taken it since.
Mm-mm.
Do you
I don't think so.
do you
either.
have any of them?
No, we only had one left.
Okay.
Just one.
But you don't feel like it did anything for your anxiety at all? Or you just had one pill?
We just
I only had the one pill, but, I mean, I went to the PET scan,
Yeah.
that's all I can say.
Well,
It
let's-
must have done something.
Yeah, let's try that then. You know, we can do that twice a day as you need it. You don't have to take it if you're not anxious. You can if you need it. It might help you sleep at night. So let's try that. Okay. So with that, I'm gonna let you guys head to checkout, okay? So what you will do is we'll go all the way down this hall. You'll go around to the right through the double doors. Checkout will be out there, okay? And I will bring you the prescription out there, okay?
Can you write down what she has, please? Write it
Yes,
down
certainly.
for me, please.
Certainly.